for the fixation of distal femoral fracture aorta 1, 2, 3 and C12. Most of the patients achieved their pre-accidental status, biological anatomical fixation achieved. Thank you, sir.
Questions are invited. Yes, please.
You were able to achieve reduction of intercondylar.
Can you introduce yourself, please? Introduce yourself.
Yes. Hello.
How could you achieve the intercondylar reduction with a single stringent pin or drill bit?
Yeah. Sometimes we able to achieve the reduction by Stillman pin. Sometimes we have to put one screws also. This act also polar screw, and a fairly outcome occurs.
Since we are getting late, we will move on to the next talk.
Thank you, sir.
I think we have missed out one name,
Ashok.
Dr. Ashok Sharma. We are sorry for that. Please.
Management of proximal tibia fracture with locking versus buttress plating, study of 30 cases.
Good morning, all of you. My topic is the management of the proximal tibia fracture with locking versus buttress plate, a study of the 30 cases. The proximal tibia fracture is account for 1% of the all fractures, with 8% of the all fracture in the elderly population. Lateral plate involved in 55 to 70% cases, medial plate involved in 10 to 20%, and both are involved in 10 to 30% cases. The two type, articular and non-articular. In articular fracture, the great therapeutic challenges include skin problems, compartment syndrome, and because of the proximity of these fractures of the knee joint, regaining full knee motion and function is difficult. There is high energy fracture in male between 15 to 50 years of the age, low energy fracture in the osteoporotic women greater than 50 years of age. The mechanism of injury, initially the fracture was low energy fractures. Now majority of the fracture was high speed motor vehicle accident and fall from heights. The fracture of the tibial plateau were caused by direct axial compression, usually with valgus more common or varus less common. They have high risk of the associated neurovascular injuries like compartment syndrome and communicating open wounds. When a single compartment is involved is usually lateral plateau. Because of the anatomical axis of knee joint is 7 degrees of valgus. Age and bone quality also influence the fracture pattern. As example, in elderly population, the depression type of fracture is more common, and in younger individual, the cleavage type fracture is more common. We evaluate the fracture by the trauma evaluation by ABCs. We look out for the associated injuries. Evaluation of the limb was done by gentle examination for knee stability, observation of soft tissue, neurovascular evaluation, and evaluation of compartment syndrome. Then we go for imaging evaluation. We should look for the peroneal palsy to rule out compartment syndrome with severe injuries, and if ABI score is less than 0.09, then urgent arterial study should be done. In physical examination for the closed injury, we classify according to Serine and Gorgian classification, and in open injury, we classify according to Gustilo and Anderson classification. The radiographic evaluation by AP lateral on large cassette view, oblique view are taken to show the posterior lateral fragments, traction film to define the fragments, CT scan to reconstruct the joint, and arterography where necessary, MRI in the suspected fracture or soft tissue injuries. The intra-articular fracture is classified according to Sechka's classification, and proximal tibia fracture is classified according to AO classification, which include extra-articular as well intra-articular fractures. In AO classification, the type B1 is equivalent to type 1 and 4th of Sechka, B2 is equivalent to type 3, and B3 is equivalent to type 2nd of Sechka classification, C1 is equivalent to type 5th, and C2 and C3 is equivalent to type 6 of Sechka classification. The treatment options are operative, non-operative. In operative treatment, plating or hybrid external fixation can be used. Our aims and objective of study was to compare the stability of the internal fixation, to compare the union rate and ability of the early weight bearing, to compare the complication rate, and to compare the relief of pain, joint function, and functional movement between two procedures. The locking plate uses single beam construct. The strength of fixation is equal to sum of the all screw bone interface. It is non-dependent on single screw stiffness and pull-out resistance. The biomechanical function is based on splinting rather than compression. It is anatomically well contoured. They secure fixing the short condylar fragments. They allow a percutaneous insertion, and variable angle locking options are available. They resist axial rotation and bending forces, and by resisting various collapse, they have decreased the need for dual plates for the bicondylar tibial plate fractures. They can be applied by MIPO techniques and allow for prompt healing, lower rate of infection, and reduce bone reabsorption. The plating relies on the principle of bridging, work best in the comminuted fracture, intra-articular and osteoporotic bones. The various literature published which compare the dual plating and the lateral fixed locking plate, they found equal or better result with the lateral locking plate. Material method, the study was conducted in 30 patients with proximal tibial fracture, 15 were treated with lateral fixed locking plate and 15 were conventional buttress plate. Assessment was done 6 months post-operatively. Savio et al. Score was used. Inclusion criteria: closed displaced fracture upper end of tibia in adults, the open fractures, gustilo Anderson less than 3A, non-infected non-union fracture upper end of tibia. Exclusion criteria: gustilo Anderson classification fracture greater than 3A, undisplaced fracture upper end of tibia, fracture in pediatric age group, and presence of infection. We use anterolateral or posterior approach. This is example of the C2 type fracture is fixed with single lateral locking plate, and this is the final range of motion at the 6 month. This is another the floating knee is fixed with the lateral locking plate, and this is the range of motion. This is another case of the proximal tibia fracture treated with single lateral locking plate, and this is the range of motion. This is the C3 type fracture is fixed with the dual plating, and because of the extensive soft tissue dissection due to the procedures, the implant has to be removed, and this is the fracture aligned varus malunion. The observation: the majority of the cases in both groups were male in age group 31 to 50 years of age. RSA was the main cause in both groups. Most patients were AO type A and C. In intra-articular fracture, most were the type 5th and 6th. The associated injury was present 33% locking plate and 40% in buttress group. The average injury surgery interval in buttress group was 8.2 days and 5.4 days in locking group. The mean duration of surgery for locking group was 66 minutes, and for buttress plate was 80 minutes. Average amount of blood loss was 215 ml for the locking group and 304 ml for the buttress plate group. Early post-operative complications like superficial infection, deep infection, hardware pain, and skin slough are more in buttress plate group than locking plate. The late complications like malunion, knee stiffness, and even non-union was more in buttress group as compared to locking group. The mean union time was 16 weeks for locking plate and 17.4 weeks for the buttress plate group. The range of motion greater than 100 degree was seen in 93% cases in the locking plate and 80% in the buttress plate group. Full vertigo was started early in locking plate group. The mean was 18.3 weeks for the locking plate and 20.57 weeks for the buttress plate group. As per Savio criteria in our series, 93% cases have excellent to good result in locking plate and 80% in the buttress plate group. We conclude that proximal tibia fracture can be better and more effectively treated with lateral locking plate. Early rehabilitation, fewer complication, early weight bearing, better and near complete functional recovery is seen with locking plate. And because of the stable and strong construct, a simple locking plate is sufficient in the majority of the cases, while dual plating may be required in many comminuted proximal tibia fracture treated with buttress plate. Thank you.
Any question, please? Yes, please.
One of your X-rays, the second post of X-ray, that is not showing, though you use open reduction, there is quite a big step, more than 5 mm approximately in the artery. So even if you are opening the joint, then still you are not able to achieve good reduction, anatomical reduction. Congruity of the joint is not maintained. One of the second X-rays which we are used blocking.
This one?
You can go back. Show your style. Next case. See the first X-ray is back. There is a big step. The first X-ray.
This was the floating knee.
What is the power for this?
This was the floating knee, and this is done by MIPO techniques.
But you have to achieve the intra-articular reduction. If you are going for plating, then you should achieve at least minimum joint congruity. You should achieve 100% reduction. But in this case, what was the reason for not achieving that reduction?
I think so. This is
There is this articular step that is showing the first.
according to literature, the 10 mm, 5 to 10 mm step is acceptable. There is a in proximal tibia fracture. There is
No.
5 mm.
Yeah, I think the problem here is that you not compressed the medial to the lateral condyle. If you had compressed it, and elevated and compressed, probably that would not be there.
What is the reason for this? This is what I was. Yes, you are.
Because
Yeah, I think it should have been
screws can
compressed.
only hold it.
So if you had put an interfragmentary compression screw before you put the plate, then probably the reduction would have been maintained. I think when there is a fracture like that, it's better to give interfragmentary compression before you put the plate.
Any more
Any other
questions?
questions?
If there is no question, we can move to the last. Infection rate.
Infection rate are very less with the locking plate and buttress screw. Because of the buttress plate, we have to do the extensive soft tissue surgery. In locking plate, we can do by MIPO techniques. We have to remove the implant in 2 cases in the buttress plate group, and none of the cases where implant is removed in locking plate.
In one of case you have shown floating knee.
Yes.
This floating knee is sustained due to high velocity trauma when a motorcycle rider sustained from the opposite side, getting right side knee injured. Then there is high velocity trauma. And because of that high velocity trauma, skin condition is not fit immediately for doing this plate fixation.
Yes.
So how many days of interval between the trauma and the operation?
15 days. 15 days. Because we have to fix the upper end.
After 2 weeks, it is very difficult to achieve implant.
Yes.
So, is there any other method for doing immediate fixation, not intermittent?
Sir, we can do fixator hybrid fixator.
Stabilization. Yeah, thank you, Dr. Ashok Sharma.
Thank you.
Now, we'll go on to the last paper of this session. That
and I hope Dr. Lad is just to come. Huh? So we start the session with your permission, and I request Dr. G.S. Kulkarni to kindly start his talk on why do intertrochanteric fractures fail and what is the answer. Dr. G.S. Kulkarni needs no introduction to us, a giant from Miraj, past president of IOA, a well-known figure in trauma, Elizaro, and whatnot. Dr. G.S. Kulkarni, sir.
Thank you, sir, and thank you for giving me 2 minutes more. Why intertrochanteric fractures fail and any solution? To me, intertrochanteric fracture is the most fascinating fractures of all fractures in the body. It is so common and so interesting. There are 14 varieties of intertrochanteric fractures, and therefore the IOACON classification needs to be modified, and we have done it and published it. The stable intertrochanteric fractures is 2-piece fractures, and DHS gives you excellent results. Unstable fractures, the 3-piece fracture, 4-piece fracture, and a shattered lateral wall, nailing is preferred. And the third variety is a very unstable fracture, is a reverse oblique, extension into the subtrochanteric area, and extension into the neck area, which is a new variety described by Kyle. This paper has been appreciated by Rockwood and Green. Kulkarni et al. Have developed the most recent therapeutic-based classification. I wish you should go through this. Now, this is our research program. Video is not working.
Pardon, sir?
Video is there. See, this is our research project, and we feel that the intertrochanteric fracture needs a CT scan and CT guided. Okay. See, this will give you, if you rotate, this rotates, and will give you that if you do a 3D video, I will give you the entire picture. Why it's not working? Entire picture. This is a split fracture, split trochanteric fracture, coronal split, and only video will give you, 3D video will give you the full picture of this. Note in this case, this is a very unstable fracture, and if you see the 3D, you can see the coronal split that has occurred, and this needs to be fixed, the coronal fracture and the trochanter needs to be fixed, and all the fragments needs to be fixed. You will see here the trochanteric fractures was fixed with a tension band wire, but this was not sufficient. We had to use another screw there when we are using a PFN. And this fracture united because I have fixed all the fragments and compressed them intraoperatively. What is stable fracture? The stable fracture is one which allows the major load passing through the bone and less through the implant. So the bone protects the implant and implant protects the bone. When the bone is bone to contact and intraoperative compression occurs, then there is no post-operative collapse. This is the principle of fracture treatment today, intertrochanteric fracture. Why unstable fracture fails? The most important is poor reduction, no bone-to-bone contact, no intraoperative compression, and this is the very, very important factor. If the close reduction fails, then you must open it and do a proper open reduction. Large displaced posterior medial fragment and the shattered lateral wall, as Gottfried has suggested. Now, recently, rotational instability is an important factor and is an issue today. The new implants like PFNA have focused on this point. As you see in this case, this is osteoporosis and no reduction. It went on to failure and we had to do replacement. Osteoporosis, this is the example of osteoporosis which needed augmentation, but we did have to do this.
I'm sorry I started.
Why unstable fracture fails? Again, poor surgical techniques. Placement, wrong placement, no respect for TAD, entry point, any implant may fail. Poor implant choice. Look at this patient. This has a reverse oblique fracture which was fixed with DHS. DHS is contraindicated in oblique fractures. And this went on to failure. There is non-union. There is an implant failure, and that is how the DHS does not work in oblique fractures. Medial cortex. Recently, Liu has done a cadaveric study, and a very important conclusion is it is the loss of medial cortex rather than the posterior medial fragment is the cause of instability. This has a very great implementation for this. Sliding hip screw is the gold standard. Your union rate is 95%, complication rate is the same, inexpensive, easy learning curve, and no damage to abductors. Intramedullary hip screw has a biological advantage, minimally invasive surgery, less blood loss, less operative time, and the mechanical advantage is moment arm is less, as you see the green line there, and when the moment arm is less, it is more stable, prevents excessive collapse, and this is important. The nail buttresses both the walls, the medial wall, the lateral wall, and that is why it has a significance. It's a load sharing, and therefore early weight bearing can be achieved, good for patients in poor health, and therefore this nailing has become most popular all over the world. Look at this patient. This has a patient had bilateral proximal femur, pelvis, acetabular, age 85, and we did the bilateral nailing on both sides at the same sitting, and it took just 1 hour. So this is the great advantage of nailing. The big fight again is whether you use a DHS or a nail for a unstable fracture. Is nail better than DHS? No. As of today, nailing is not superior to sliding hip screw. Say April 2010, Cochrane Library data and M.J. Parker. If so, why do you want to use nail? The Baumgartner has one answer, that is percutaneous and limited opening. I have two more reasons why I use nailing. Our patients are undernourished, poor in general health, with comorbidities. Therefore, we must finish the operation as early as possible with minimal blood loss and minimal soft tissue dissection. Therefore, we prefer nailing to DHS. Reverse oblique, as I have told you, the case showed you, reverse oblique is contraindicated in DHS is contraindicated because the forces that are acting on the head go on the plate, act on the plate, and the shaft moves medially, and therefore DHS is contraindicated. And the nail buttresses on both sides. Similarly, DCS also is helpful in these cases. So these are the two examples of reverse oblique. One is treated by nailing and the other is by DCS. Both work well. Now, shattered lateral wall is as important as the posterior medial wall, as shown by Gottfried. Due attention is not paid to this. Buttressing prevents the collapse. Now, you must reconstruct either by a tension band or by a trochanteric plate. So, reconstruct it is important. Again, the Su from Taiwan is published article in JBGH British, and that is, he has measured the lateral wall and quantified it. You take a point from the base of this, you gather 3 centimeters, a point from here, the DHS is, barrel is inserted. From there you take the point here up to the fracture site, and this is the measure. If this is less than 20 millimeters, then the breakage occurs and therefore do not use DHS. Whereas if it is more than 20 millimeters, you can use a nail, DHS here, if the wall is thick. Why the lateral wall is so important? Because it causes excessive collapse if the lateral wall is not reconstructed and medialization occurs. In this case, there is a non-union here, and note that the excessive collapse has occurred and the medialization occurred. This has caused lot of pain to the patient and therefore the DCS is better in these cases, or you can use the nail. This was treated with DCS with union. Varus is an excellent recipe for failure. You can see here, this is a 4-feet fascia. This was fixed in Varus, and note that when you use nails here, like these 2 nails, they are all in the superior quadrant, and therefore it fails. As you see, it is failed, and this was treated with a valgus position of the head in the DHS, and it united. So, IT fracture, extension into the neck of the femur, an additional pattern has shown by Kyle, has shown this pattern, and you can see this is the pattern. We had 3-4 cases, and he suggested arthroplasty, but this patient could not afford, so we did a valgus position of the head. You can notice the valgus, reconstruction of the lateral wall, and note this screw, what we call a calcar screw, is again very important. It has 3 functions. One is it stabilizes the trochanter, it gives more stability to the fracture, and also as it is an angle stable, it will not allow post-operative collapse. This is our prize case. This lady had, 65-year-old lady had fracture of the acetabulum and dislocation of the head, and there is a notice here, there is a trochanteric fracture, the lateral wall is shattered, medial wall is shattered, intertrochanteric neck fracture. So everything was there. This was treated with reduction of the plate and fixation of the posterior wall, and then we again treated this, making this in a valgus position, reconstruction of the lateral wall, and this patient, to our surprise, walked in 4 years after 4 years, and noticed the fracture has united, and she went back to her work. newer designs have come. There are two worth mentioning. The market is flooded with implants. There are two implants. One is the PFNA and the second is the Smith & Nephew integrated nail, what is called a InterTan. This is it also gives you intraoperative compression, and this PFNA has become popular now. The advantages are the single helical blade prevents rotational and varus instability. This is another very important point of PFNA is that compaction. When you insert the helical blade, it compresses the cancellous bone and impacts it and converts it into a more dense bone, and that gives more stability. The compaction is a very important point. Another point is intraoperative compression. This is very important. These three, the intraoperative compression is important because it will not allow the post-operative collapse. We have been taught that the collapse is necessary because in a DHS, the fragments will settle in a stable position due to collapse. But this is not so. Collapse of the collapse of the fragments means collapse of the hip. So post-operative collapse is not necessary. PFNA is, in this case you can see here, this is a very reverse oblique, four-part fracture, lateral wall is shattered. So this is, we treated with PFNA helical blade. I have told you, this is what we call a calcar screw. This has angle stability, and this screw have stabilized the lateral wall, reconstructed the lateral wall, and you can see the fracture has united nicely. Another example, you can see this also a bad fragment. Yeah. Then we have, there are 341 cases treated by PFNA by Liu in China, and 151 unstable cases. There was 5% revision rate. One more paper from Chennai, Ashok Gavaskar, 122 cases, again the revision rate was 5%. We have 48 cases treated, no revision so far, follow-up is only 13 months. We had 3 cases, poor reduction. The take-home message is the anatomic reduction, bone-to-bone contact is most important. The second part is intraoperative compression is necessary. When you do these two are there, then there will be no post-operative collapse. The post-operative collapse is again the special instrument that you have to use is the PFNA or the integrated nail. So all these three together, the anatomic reduction, intraoperative compression, and the type of nail used, then it will prevent the post-operative collapse. Post-operative collapse is one of the causes of failure. Reconstruct the lateral wall, and we prefer PFNA. The placement is in the dead center.
Sir.
Finish. Last line.
More than desired time, sir.
Yeah, this is the last.
Taken more than desired time. This is 3 minutes more.
Oh, sorry.
Thank you.
Thank you, sir.
Are there any questions from the floor?
Any questions from the floor?
Medullary fixation in intertrochanteric fractures. Intertrochanteric fractures are becoming increasingly common and account for more than 50% of the hip fractures because of rapid increase in elderly population. Number of treatment options are available. Unstable patterns are more common. Shortening coxa is the usual complications. Treatment aims at higher rate of union, less complications, early mobilization, and the functional recovery to the pre-injury status. There are certain factors which are not our control, that is, the factors which are under our control. There are certain factors which are beyond our control is the quality of bone, fracture geometry, and the comorbidities. But there are certain factors which are definitely under the control of the treating orthopedic surgeon, that is the quality of reduction, selection of implant, and the placement of the implant. The days have changed. In earlier days, the bone unites. That was the only task of the orthopedic surgeon. But now, healing is no longer the success. Healing in the good anatomical position along with the full functional recovery to the pre-injury status as well as the early ambulation is the aim of the treatment. Residual deformity and the functional outcome matters. Per-operative insult also counts. Stable reduction of an intertrochanteric fracture requires posteromedial cortical contact or, as very rightly said by Dr. Kulkarni, the medial contact between the major, proximal and distal fragments to resist varus and posterior displacement. Unstable intertrochanteric fractures are technically much more challenging than the stable fractures. When internally fixed, the osseous fragments of these unstable fractures are not able to share the weight-bearing loads. Therefore, the loads are predominantly borne by the internal fixation device till the fracture heals. Reverse oblique fractures, fractures with the butterfly or the comminuted posterior segment, subtrochanteric extensions, transtrochanteric fractures are the typical unstable patterns, and they include accurate realignment of the fragments, proper implant selection, and proper placement of the implant is important. Dynamic hip screw, though, has been the gold standard in the treatment of intertrochanteric fractures, but there has been some dissatisfaction with the use of the DHS, and that is the resultant deformity in unstable fractures due to excessive sliding of the leg screw, which leads to limb shortening, medialization of the distal fragment, superior cutout, risk of pull out of the plate in the osteoporous bones, higher rate of infection because this is an open procedure. You can see with these diagrams the excessive sliding of the leg screw within the barrel plate, superior cutout by the DHS, and when there is a no lateral wall, then and the DHS has been done, there is excessive medialization, collapse, shortening. This is a diagram to show biomechanically which is a more stable device, the DHS or the PFN or the intermediate devices. The DHS works on the principles of the third class lever, and as this is subjected to the weight bearing, the plate tends to come out from the bone, superior cutout. Whereas the intermediate nail works on the principles of the first class lever, lever arm is short. They are biomechanically, they provide the more strong constructs. Intermediate location theoretically provides more efficient load transfer than the dynamic hip screw. Shorter lever arm decreases the tensile strain on the implant, decreased risk of implant failure. It is not only the reduced lever arm that offers a clinical significant mechanical advantage, but the intermediate buttress that the nail provides to resist excessive collapse. A slight bend in the nail conforms to the natural bow of the femoral shaft. 10 degrees of anteversion matches the angle of femoral anteversion. Any amount of combination of fracture do not increases the need for periostal elevation, operation time, and the blood loss. Intermediate location limits sliding, thus limb shortening and deformity because the proximal fragment abuts against the nail, thus controlled fracture impaction is maintained. Reaming provides internal bone graft. If locked in dynamic mode, permits controlled compression at the fracture site, provides axial and rotational stability. Intermediate devices are 76% stiffer in torsion and 37% stiffer in bending than DHS. Is a closed procedure, shorter operative time, negligible soft tissue dissection, negligible blood loss, permits early mobilization, pre-injury ambulatory status, and thus decreased morbidity. There are some limitations. As the person ages, the femoral diaphysis enlarges and the femoral bone increases. So one should be aware of putting a nail in these patients because the nail may impinge against the anterior femoral cortex and causes anterior thigh pain. The distal locking screw can be a stress riser. Trochanteric fractures below the level of the lesser trochanter, regardless of the fracture pattern or the degree of comminution, can be treated by first generation nails. First generation nails provide inadequate fixation if the fracture extends above the level of lesser trochanter. Inadequate fixation by first generation nails led to the development of new generation of interlocked nails, which provide better fixation by directing screws into the head of the femur and also permit distal interlocking. The various varieties of the interventory devices are available. The commonest in use are the PFN and the PFN-A. PFN has got the two screws that stabilize the femoral head, thus provide a better rotatory control. Proximal femoral nail is 25 centimeters in length and available in 130 degrees and 135 degrees. In the TFN, the leg screw has been replaced by the helical blade, and it provides improved resistance to the varus collapse because it permits compaction of the bone around the helical blade. Helical blade has been shown to remove less bone in femoral head, and it permits compression. PFN-A was modified to fit the Asian population, and this is the PFN-A Asian size, has a better fit to the small trochanteric area and the narrower intermedullary canal of the Asian population. The long version of the intermedullary devices is indicated for low and extended subtrochanteric fractures. Ipsilateral trochanteric fractures combined with fractures in the proximal femur, pathological fractures. There are absolute indications of the intermedullary devices: unstable fractures, segmental fractures, and the fractures with osteoporosis. Relative stable intertrochanteric fractures and can be treated with the both the techniques, DHS or the intermedullary devices. But beware of increased anterior bowing of the femur in elderly persons. Important points for the intermedullary nails: fracture should be reduced by closed or the open method before making the entry point. Assess the neck shaft angle. Proper entry point in AP view, medial tip of the trochanter, lateral view, center of the neck trochanteric junction. Avoid varus. This is very, very important. Perioperatively, the varus should be corrected. Do not accept varus reduction at all. Varus angulations makes the femoral neck more horizontal and therefore increases the lever arm, loses the biomechanical principle. The leg screw gets highly placed, increased risk of device cutting out, coxa vara shortening. Proper length of the nail is a must. Have relatively, though short PFN, have a relatively reliable targeting of the distal interlocking screw through a proximally attached insertion guide. Late femoral fractures at the tip of the device or through the distal locking screw of the standard PFN and the higher risk of further falls in this population. Longer version of the intermediate devices ending in the supracondylar region have been evolved. Unless indicated, distal locking is not a must while using the long PFN. Of course, it has to be done if there is extensive comminution, the marrow is roomy, or in segmental fractures. Short nails can be used for undisplaced fractures, minimally displaced fractures, fractures with a stable pattern. Protect the length of the femur in elderly persons with long nails as they have propensity to fall and risk for subsequent fractures. If there is any doubt about the stability of the fracture, a long nail should be used. Use of shorter nails in unstable patterns is associated with higher incidence of Z effect. Proper placement of the screws is the must. The tip of the GT and the stabilizing screw and the leg screw must be at the same level. Tip apex distance must be honored. Avoid distraction at the fracture site. When locked in distraction, device withstands all the load and there is risk the fracture will go for non-union. If continued as such, the implant will fail. I have treated 120 cases by PFN. Clinical radiological union was achieved within 3 to 4.5 months. Widening and splinting of the Gerard trochanter occurred in 10 cases, which healed uneventfully. Varus angulation was seen in 4 patients. Shortening more than 1 centimeter was not seen in any case. Superficial infection in 2 cases. 2 patients died because of medical complications. Few cases treated by the PFN. The clinical results, the X-rays showing full range of motion. Of course, there are few complications. Non-union in 2 patients, Z effect in 1 patient, superficial infection in 1 patient, distal screw breakage in 2 patients, fracture shaft femur in 1 patient, where I use a short PFN. Superior migration of the screws in 2 patients. Innumerable reports are available in the literature on this subject. Few advocate DHS is superior. Others says intermedullary devices are superior. Early results with intermedullary devices are good, but long-term results are the same. Majority of the reports, however, they advocate intermedullary devices for unstable intertrochanteric fractures. Study JBJS. No difference in the operating time, blood loss, wound complications, stay in hospital. No difference in failure rate with the DHS or with the intermedullary devices. Another study, no difference. Another article, injury 2002. PFN is a good choice for stabilizing subtrochanteric fractures. The use of the PFN for unstable trochanteric fractures is very encouraging. Another study 2004. PFN is a suitable implant for unstable fractures. Yet another study 2004. Unstable fractures, intermedullary implants are superior. Yet another study, the complication rate is considerably less while using the intermedullary devices as compared to extramedullary devices. Faster return to the perioperative ambulation, reduce operative time, less blood loss when intermedullary devices are used, especially in patients with unstable fracture patterns. So they prefer the intermedullary devices. Intermedullary devices is a biomechanically stronger construct. Asymmetric blood loss was less, healing is faster with the use of the intermedullary devices. PFNA is a very effective and safe method in the treatment of different patterns of peritrochanteric femoral fractures. The fixation is adequate to maintain reduction over time, even in osteoporous bones, with the use of intermedullary devices. Authors have advised the use of short medullary nails for the fixation of unstable proximal femoral fractures. Lot of studies. The proximal femoral nailing anti-rotation achieves primary stability comparable to dynamic hip screw blade. The proximal femoral nailing anti-rotation combines the biomechanical favorable concept of intermedullary fixation with a minimally invasive surgical technique, which theoretically may be advantageous in the clinical use. Further biomechanical studies are required to clarify to what extent the results of the present study can be transferred to the clinical situation. There is one study, 2012, more expensive on 14,915 patients treated for peritrochanteric fractures. More expensive intermedullary implants do not lead to a better clinical outcome in long term, though the short term results were good. Nail fixation, nails seems to prevent failure by opposing the, carry on message. Treatment of intertrochanteric fractures is based on patient's medical condition, pre-existing degenerative arthritis, bone quality, and the biomechanics of fracture configuration. Stable trochanteric fractures can be treated safely, both by intramedullary or the extramedullary devices. But unstable fractures are better stabilized by the load-sharing intermedullary devices. Intermedullary devices are biomechanically superior. They shorter incision, less blood loss, less operative time, permit early mobilization, and achieve pre-injury ambulatory status faster. Long intermedullary devices should be preferred to avoid the risk of discomfort, fracture at the distal locking screw of the tip of the nail. Thank you very much.
Dr. S.K.T. Raja, please.
Respected Dr. Lad, my dear friend Dr. Pruthi, and friends. Both the previous speakers have made my job easier because what they have missed is the total bust that we are discussing intramedullary fixation and extramedullary fixation. We are not discussing DHS. Unfortunately, all the criticism that they are based on is on the DHS. DHS is just one device of the other extramedullary devices that are available. So you cannot compare a device which was there 30, 40 years back to be still doing the work for you when you have better extramedullary devices. So why just blame the DHS? There are improvements in the extramedullary fixation which you should be speaking on. We have discussed these problems, malunion in coxa vara and external rotation, osteoporotic bones, comminution, greater trochanter, lesser trochanter, we've all discussed that. We've discussed the biomechanics. We all know that intramedullary devices would be stronger biomechanically. There's no controversy regarding that. The debate is on intramedullary nailing and extramedullary fixation, not just on intramedullary nail versus the DHS. So why just speak on the DHS? The theoretical advantages of the intermedullary devices are all there. More efficient load transfer, shorter lever arm and tensile strength, advantage of controlled fracture impaction, intermedullary location limits the amount of sliding, shorter operative time, we all know that. Other advantage of intermedullary devices, small incision, less breast loss, less radiation exposure, early weight bearing, shorter hospital stay, blah, blah, blah. Disadvantage of intermedullary nailing nobody has thought of, that there's a huge learning curve. Beware all the youngsters over here. You have to do it well. You have to have your entry point well. You have to take care of the femoral bowing. There are a lot of things which are there. So per-operative complications, even with the first generation nail, Zickel himself had a per-operative complication rate in his initial study of 37%. Go back and study Zickel's first paper. You'll see that the per-operative risk, even from the master, was so high. And the costs, of course, are much more. Hardy in 1998, that was the earliest days when the debate started, 100 intertrochanteric fractures, comparison of a DHS with intermedullary devices. He also concluded that routine use of intermedullary hip screw cannot be recommended for intertrochanteric hip fractures. Probably best indicated for intertrochanteric fractures with subtrochanteric extension, that is, you have things which are unstable. A recent nail plate fixation for intertrochanteric studies. This is a study which was done by the American Board of Orthopedic Surgery database. Overall, patients managed with plate fixation have slightly less pain and deformity in comparison with those managed with intermedullary nailing, with no significant differences being identified in terms of function and satisfaction. Patients managed with intermedullary nailing had more procedure-related complications, beware, particularly bone fractures. So the conclusion from 1999 was to 2006, a dramatic change has occurred in the surgeon preference for fixation device used for the treatment of intertrochanteric fractures has occurred among the young orthopedic surgeons, and this is industry driven. All the new devices and all that, people feel that this is the glamour of the whole intertrochanteric fixation, and more of our youngsters are shifting to that. But is that borne out by the facts of the case? The Cochrane database system review in 2005, the scientific evidence, at least in the English language literature, does not support the superiority of intramedullary nail fixation over standard sliding compression screw and slide plate fixation for the treatment of intertrochanteric fractures. In fact, the concession from the orthopedics literature is that intramedullary nailing fixation is associated with a higher complication rate and no better outcomes. Even my previous speakers have said that the ultimate long-term results remain the same. But per-operative failures, historically a high rate of peri-implant fractures has been a major concern after intermedullary nailing for trochanteric fractures. So the dynamic hip screw is preferred overall. Simple technique, better instrumentation, optimal fixation, scope for lag effect, better overall results, fewer complications, both per-operative and post-operative, if you do the technique well. And it is suitable. In my whole practice, I've never had the use of putting in a single intermedullary device for even osteoporotic fractures because I maintain a very strict regime per-operatively. And this is what I have come across. We have done a lot of studies on the trochanteric trabecular pattern and the trabecular pattern of the proximal femur, and we feel this is where you have to put in your device. If you put it anywhere else, it fails. The decussation of the trabeculae is where your threads have to be engaged. Baumgartner, no issue. I don't believe in Baumgartner and the TAD. You have to put in your threads where you have the decussation of the trabeculae in the AP and the lateral view. So even osteoporotic fractures can be treated very well by this. And then you can add another screw over there, which has been done by people. The most important thing is the greater trochanter. If you stabilize the greater trochanter, then the lateral sliding gets limited. That is the key issue, that the trochanter and the lateral wall has to be stabilized well. If you do that, the sliding is automatically controlled. And if you are opening up, you have an advantage also of doing primary bone grafting. And I don't shy away in osteoporotic bone from putting an extra bone graft on the posteromedial side where you have a defect. So even primary bone grafting in osteoporotic provides you with a biological way of early healing so that you don't have implant failure. Unfortunately, majority of the studies have compared PFN with only compression hip screws, that's what I said, rather than extramedullary devices, Bhandari et al., 2009, latest. But there are disadvantages of the sliding hip screw. Excessive slide leads to medialization, shortening. Average setting time in stable fractures is 5.3, unstable fractures 15.7. So we agree to that. And this is how the medialization occurs, and this is not acceptable. We all believe that this is not acceptable. Fine. But that is only with this. Here it went on to heal, the fracture also medialized well, but in an osteoporotic bone, patient had an excellent result. But still, I would say that the shortening would be a limitation. Number of extramedullary devices came up. I was not very happy with this. But the most important thing is stabilization of the greater trochanter by various means, by the use of an anti-rotation screw. I call it a buttress screw, and or a TPS, a trochanteric stabilization plate, or a tension band. The DHS alone is not sufficient. An anti-rotation screw, we call it the buttressing screw, should always be added for increased support. This is also essential for fixing a large trochanteric fracture, and a large washer provides support and compression. And this is what you do, and if both of them are parallel, then the support is there for it to heal without much of collapse. So this is how it was. And if you put in this, it heals even in osteoporotic bones and the patient's there. So it goes on to heal very well. So in all these cases, it healed. So the carry-home message is a close adherence to standard technique, proper restoration of anatomical configuration, and a closely supervised post-operative management yields good results even in osteoporotic bones. But extramedullary fixation we are talking about may be the only answer for some places. Malunited fractures, failed internal fixation devices, we've seen that they've gone on to fix it with external devices. Non-unions, Dr. Kulkarni mentioned, it had to be fixed by extramedullary devices. Peritrochanteric fractures in ankylosed hips. I've had a case where the hip was totally ankylosed, bony ankylosis, and you had a fracture. You can't reduce it by any other means but by putting in an extramedullary device. So these are some examples. This was a case which came 3 months late, and then we fixed it with this and an extramedullary device. You can reduce it. Because of shortage time, I'll just come to the fractures which are there, which are the so-called unstable reverse oblique. So we have this device which we have said, extramedullary device. We call it the Cobra hood plate, which we've been using in our own department for the last 20 years. From 1986 onwards, when we first presented it in the Delhi conference, we've been using this, and this has given us very good results. It is based on the tubular pattern of the proximal femur. A part of that I've been presenting this since 1991 for the Silver Jubilee commemoration lecture, and based on the tubular pattern which we have found out from here, we have been using this device. I won't go into the details of the tubular pattern there, but that is what we have done. And this is the device which said that if you use 3 screws, which are based on a number of principles, an extramedullary device can be a very good device, a simple method, using AO principles, using your tension band principles and other principles, you can fix it very well. And you can see, these are all unstable fractures which have been anatomically reduced, which have been fixed very well, and they've gone on to heal. These are all examples of how extramedullary devices can give you a very good fixation. Your AO principles, which are taught to each and every postgraduate, can be utilized for fixing all these fragments in position, and you can have a very good anatomical result without a millimeter of shortening. And these are some examples of that where you can use it. And even in subtrochanteric fractures, you have these. It goes on to heal when you have comminuted subtrochanteric fractures as well. So the Cobra hood plating is based on the following principles: the tension band principle, the anti-glide principle for reversed oblique fractures, buttress plating for trochanteric comminution, tubular patterns of proximal femur for improving quality of fixation, because we've said that the threads or the screws in the trochanteric and the head has to go in to where the tubuculi are important. And this we have already published our work also earlier and presented it in various conferences in the IOACON. A cross-screw fixation of Garden. We all know that in 1964 there was a cross-screw fixation for intracapsular fractures. And that same principle is used here also for a cross-screw fixation, which improves the rigidity of fixation at the site of crossing of the trochanteric screws. So it increases the stability of the device. So the Cobra hood plate is more cost-effective than the DHS and the DSP. So the take-home message is the sliding compression hip screw is a simple device. The technique can be easily learned, and the details must be understood and followed. Anatomical reduction should be the aim while fixing all fractures, as has been pointed out by previous speakers. The intermedullary devices have a theoretical advantage based on biomechanical principles. However, the jury is not out for their superiority over extramedullary fixation. The only clear advantage quoted in studies is for unstable fractures. We feel our device, the Cobra hood plate, is an answer for such fractures. Therefore, we find no need for the use of intramedullary devices at all. Thank you very much for a patient hearing.
Thank you, Dr. Raja. And now I invite, sir, Dr. Gautam Chakra.
फर्स्ट स्लाइड लगा यार
Obviously, sir.
रहने और नहीं ये फिर बैक करो फर्स्ट पे जाओ यार छोड़ एक से छोड़ ऊपर जा तुम पीछे जा रहे यार छोड़ और ऊपर छोड़ छोड़ तो जरा छोड़ दो तुम उल्टा यार बेटा अरे क्या कर रहा है यार तो पूरा इसका मजा ही बिगाड़ दिया
हाँ, छोटा सा।
मजा बिगाड़ दिया यार
जी।
क्या कर रहा क्या कर रहा Professor Pruthi and all the doyens of orthopedics who have spoken before me. They have talked about different types of trochanteric fracture and their management. I am a dwarf in front of them. I will just tell my experiences how to manage the failed fractures, how to manage the failed fractures. I am using the word failed instead of malunited because malunited will act like a very strong weapon in the hand of CPA lawyer who is fighting against you. Now what happens once a trochanteric fracture fails? There is abnormal mechanical axis which causes irregular weight transfer leading to secondary arthritis, rotational or angulatory deformity which interferes with the gait. There is infection, there can be infection rather, overriding or bone loss causing shortening. Now the question comes up, when to treat a failed fracture? When it impairs function significantly. Best treatment of a failed fracture is prevention. A skillful and thoughtful management at the first stage prevents majority of the problems. But unfortunately, once the primary treatment has failed, one should aim for, number one, union, number two, alignment, both angulatory and rotatory, restoration of length, and actual position of fragment. Once a case of failed fracture comes to us, one should not rush in immediately. One should wait for the proper time. The proper time is when the brunt of the first surgery has been overcome. Usually textbooks say it is about 6 months, and one should assess the condition of the soft tissues. If the soft tissues are not fine, you are going to end up with a problem. I'm not going to talk much about the theory. I'm going to present a few cases. RP, a case of aseptic non-union. For 9 months he was in traction. The fracture failed to unite. A DHS with a derotation screw was done. Unfortunately, in 3 months he united. A second case in which PFN was done. You can see the position. No comments about the first surgery. DHS was done. It was augmented with autogenous bone graft and some G-bone cement, and you can see the end result. Third case, DHS was done. The screw that failed to slide back, it eroded the femoral cartilage as well as tabular cartilage. Both the cartilages were damaged, so there was no alternative but to replace both of them. Here's another case where Jewett's plate was done. It was replaced by open reduction internal fixation, bone grafting, and PFN had to be done. A case of ununited fracture femur, subtrochanteric fracture. We can see the distal screw has been bent. The fracture site is showing hypertrophic callus, but it did not unite after 5 months. It was replaced with DCS and bone grafting. You can see the end results. Another case, Mukesh Bhargav, grossly comminuted trochanteric fracture. A long PFN was done. After 3 months, we can see there was very little callus formation. We were thinking of doing a bone grafting, but fortunately, both for the patient and for us, it united in another 3 months. Shanti, a young lady of 75, diabetic, hypertensive, asthmatic. Her movement was restricted in the house. She came for 4 months in a Thomas frame. We had to remove the head and replace it with a cemented bipolar, as her movement was very much restricted and her demands were very little. You can see the clinical photograph. Munna Ram, a simple case of trochanteric fracture, 2-part, PFN was done. The patient went home happily. After 3 months he comes with the 8 mm screw penetrating into the acetabulum. The screw had to be removed because the fracture had not united, so we couldn't take care of the whole implant. Unfortunately, the fracture got infected. We waited, and then we removed the implant. The patient is happy and he has consoled himself with the shortening. Another case, KP, where for a subtrochanteric fracture, K-nailing was done. For 5 months, the fracture remained ununited. The nail had to be removed. Interlocking was done with bone grafting. Gradually, one of the implants that became loose, it had to be removed. Some debridement had to be done. And finally, the fracture united after 18 months. There is another case of infected non-union, where interlocking nail was done. I just got a rush nail coated with antibiotic mixed with cement, as propagated by Professor Kulkarni. We waited and waited. In 2 years, the fracture united well. The infection got controlled. Here is the patient. We asked for the removal of the